My name is Andreas Berglof. I'm working with RFSU, the Swedish Association for Sexuality Education. I have a question for Dr. Johnson about the country coordinating mechanisms, because that's where everything is sort of boiling down at the end, isn't it? And friends working or representing organizations for people living with HIV who are not invited to the CCM meetings that occur, Moldova, Albania, for instance, here in Europe. What is your response to that, and how, if that still occurs, how can we improve that? Thank you.
Yeah, please answer. I think
it's on now.
Yeah, it is.
So thanks. It's a vitally important issue. As everybody knows, the CCM, most people, I'll just say it briefly for a few that may not. The CCM is a Global Fund mandated body that is legally responsible for the application and the management of the funding, and it by its formation has to have public and civil society and private engagement, and it's a tool for that. At the time of the major Global Fund changes that happened and led to the new funding model in 2011, 2012, everything was on the table for rejigging, redoing, reorganizing, and many things were. And we talked internally about the CCMs and what can and should be done to make them most inclusive. And to be honest, there are steps taken in terms of constituency membership and mostly this process of country dialogue where the fund portfolio managers take a closer look and are in country every month examining that. But nobody could come up with something better than the CCM. So I would say the CCMs are variable, to be perfectly honest, and I think the fund portfolio managers in the countries that you mentioned either do or should know about those things and engage with the other partners around the table to be sure there's the best representation. But the thing that's come into place is this process of country dialogue where CCMs are mandated to demonstrate that they're going beyond their own membership and that they are including other voices in the preparation of concept notes. So when that's not happening, we'd like to know about it, and we could talk offline about whether that has or should be reported to who.
Thank you. Yes, absolutely. Maybe you can, yeah.
Here? Yes. Just to say that we also find, from SIDA's perspective and the Swedish embassies, that sometimes partners, civil society organizations, are not really aware of when key processes are starting in countries, like development of a concept note for the Global Fund, for example, which is extremely important, of course, to be part of. And there I think that sometimes the sharing of information can be done through actors like you here, NGOs working in the north who are aware that these processes take place. Be in touch with your partners at country level to inform them, and also ask embassies, your key donors, like-minded donors, inform them, look, there is an organization for people living with HIV who have not even been at the CCM or who have not been invited. Why is that? You know, use all your contacts to support or push the Global Fund to invite them.
I'd hugely emphasize that point about the political mobilization. What I've said many times, and hopefully other people agree with, the Global Fund does not want wonderful donors like Sweden and the UK and France and Germany and the US and Australia and all the great donors. We don't want them to just write a check and go home. We want them to be active. We need that political mobilization. So thank you for saying that. It's super important.
Thank you. And do we have any more questions? Is this like after lunch coma or question over there? Hello?
Okay. My name is Malaika Mikkelsen. I'm from Shifo Foundation. And I just wanted to say that I was very happy to hear Dr. Johnson talk about the importance of gathering data, because one of the gaps that we have in addressing the issue of HIV is the lack of quality data that's not aggregated, but that is broken down to a very local level. And Dr. Ekström touched on this earlier as well as P. Engstrand, in terms of strengthening health systems. And I think that it's something that ought to be remembered, even as we talk about the very lofty goals of reaching, for example, 90, that we have to do this within the local context of gathering quality data. So I think that's a very important point that Dr. Johnson touched on. Thank you.
Thank you. Absolutely.
It's so important. I want to, sorry to talk too much, but it's absolutely important. And what I want to take your comment and extend even further, and I think it was emphasized in many of the presentations, is the use of that data. Because you're right, there's a lot more that needs to be collected, but there's also an unfortunate historical trend of collecting data and reporting it up the chain. And then you get a nice, nice book that has a lot of facts and figures in it, and then it gets sent up to UNAIDS and all of that. What we're talking about today is the other side of that, which is how do you take that data, generate it, analyze it locally, and how do we empower and support the capacity of individual site managers to do that? And again, we've heard about some of the models today, but it's not common. And so thanks for that comment, and I just want to even further emphasize into this whole cycle of collection and use, which is not often done.
Thank you.
I agree and disagree. Indeed, we need data, but please keep them as minimal as possible, because what happened to happen for usually is that donors, they need to be showing what has been done with the taxpayers' money, and basically they're going to ask a whole series of evidence and data indicators filled in, and basically this takes away the time of any health worker to spend qualitative time to clinically monitor the patient, treat and diagnose the diseases and so on. And basically this is a serious disbalance sometimes about the cumbersome weight of data collection. What we need as data are 4. How many were tested and have been linked to care, how many have been put on treatment, how many do come back continuously, and how many remain undetectable. These are the 4 data, but when you compare this to the number of the mountains of data that are requested by international donors towards governments, we're killing the investments. And this is underlying that, I would say, and in that sense, maybe a sentence Saar didn't stress enough in the in her presentation, is about demedicalization. We need to make a difference between the people that need professional support, medical support, that are sick, that have fever, that have a disease, and others that have only the need of having a drug supply. So the cutoff between clinical care and drug supply. And drug supply should get out as much as possible from professional hands to be able to go as close as possible to people. And for this, of course, the closer we are in the periphery, the less data we will have. So let's be very careful, and let's try to not anymore speak about patients. Let's speak about people who need these damned drugs to be as close as possible to their treatment, to their house. Thank you.
Thank you, Mr. Bayet. I saw Malaika waving, but I also saw Anna-Mia, so I'm going to allow Anna-Mia first, and then you'll get the microphone back.
So I also would like to agree and disagree with you, Mark, on this data issue. That I entirely agree that way too much time is spent by very scarce health workers to fill in multiple records. But I think all of that could really be simplified if donors managed to coordinate themselves, and also if we could digitalize data, then it could be one electronic system, all using, handheld electronic data entering, etc., to make this automatic. And I think we need that also to evaluate interventions, because we roll out now numerous different. We've seen here how many interventions that are being piloted, and these must be evaluated in terms of cost effectiveness, etc., and sort of cost utility, to see what really countries with scarce resources should invest their scarce resources into, and how to make priorities. So we really need to use data. And I would like to then emphasize the need of the existing, for example, community data collection network called In Depth, in terms of health and demographic surveillance sites that are. It's an umbrella organization collecting data from 60 rural sites with an average of 60,000 people in the periphery where nobody else collects data, and that data has so far, as you say, data has been collected for reporting purposes and not for actually use, not to be used. And I was recently at a meeting with the Ethiopian ministers of health. They have several different ministers, and they said it's time we start collecting. They're talking about in health data transformation, data revolution is actually what the information revolution, I think, is the word they use, which is very impressive actually, to see how they want to use data much more locally, and data to be collected locally and also used locally. And we're talking district level, even village level perhaps, or health facility level, and that requires that data is timely collected but also analyzed in a very, very simple manner, sort of graphically illustrated automatically by a digital program, for example, so that managers every month can, for example, see how many drugs, how much drug do we have in stock, how many are retained, how many have come back to pick up their drugs. And now it's so cumbersome to calculate all of this, so it's reported like 3 years later, with huge investment of time, waste of time. And this is something where research needs to go in also to see how can we make data collection and use much more effective, quick, timely, easy, sort of user-friendly. I think it's really, really crucial for the future.
Thank you. Malaika?
I wanted to say that I completely agree with what you said, Mark, about the importance of contextualizing the data that we collect and what is it being used for and who is it being used by, and the process of data collection. And touching on what you said just now, Anna-Mia, about making data collection as easy as possible and as close as possible to the user in the community, whether it's the patient or whether it's the health worker. And that's one of the things, sorry to make a shameless plug, but that's one of the things that we work. We create software so that data can be collected in a very simple, automatic and direct manner, which frees up the nurses and healthcare workers from administration and report generation. So instead of spending 4 hours per day on administration and creating reports that are lost in the system, the data is relevant and is collected, what they need, when they need it, and to be used by the community. So I think that's a very, very important difference.
Thank you. Lennart Fjellmaker, next to you. Is it on?
Yeah, just a quick remark, not a question. and thank you to the Global Fund for the openness in your reply to the question from Andreas, and also Pia already commented upon this. But I mean, these things are extremely important for us to hear. So thank you for bringing them up. And as you know, most of you, because you are so well educated on all this. But you know, on the Global Fund board, we work in a constituency called Point 7, and right now it's Denmark who represent that constituency on the Global Fund board, and the deputy board member is Norway, and then in the constituency is also Sweden and Holland and Ireland and Luxembourg. So if we look upon that constituency, we are represented with embassies quite at large. So we have possibilities to work on the ground. Sweden is not in all countries. We are in many countries in Africa. But if you look upon the constituency as such, it is very much possible to work through the constituencies. So we can both work at the country level, but also on the board when we get to know things like this. And we also feel a great openness from the Global Fund when we discuss these things about CCM, for example, and how it works and how it does not work. So it's good that you bring it up, but also a good discussion here. Thank you.
Thank you. And I think Kerstin Åkerfeldt had a question or a remark. We'll see.
Yes, it is. It's a comment and a question. A comment in response to something that Anna-Mia mentioned around drugs, and that we now have very, very good drugs available. And you mentioned that the medical bit is basically solved, but I just want to challenge that a bit when it comes to access to newer medicines in countries, in middle-income countries, and maybe colleagues from South Africa can comment on how patent barriers are posing a threat to actually continue having access to those really good drugs in other countries than Sweden, for example. But also when it comes to stockouts, it has been mentioned a lot, and I think that is, we all agree that it's essential to have uninterrupted access to drugs in the clinics. And I also want to ask actually the Global Fund, going forward with this approach on differentiated care, how much you see this this sort of line of supply, uninterrupted supply, also as your responsibility to ensure that in country clinics have, and there's beyond sort of the delivery at country level, that also in country drug supply chain is functioning.
Please. Dr. Johnson.
What's the answer of the afternoon is yes and no? Is that where he says? I mean, I guess what I would say is it absolutely is our responsibility. It's the Global Fund's responsibility to make sure the money is spent wisely. And if there's leaky supply chains, it's not being spent wisely. So that's clear, complete agreement. The problem or the challenge that we all need to work together on is the Global Fund is a partnership organization with no field staff and very, very limited technical staff in Geneva. So we need to be working, and we are working with partners in a lot of different ways to try to detect and repair those problems when they exist. The best example right now that some of you might have to be pretty close to the Global Fund to be in the middle of this at this point because it's early on, but there's a fairly new initiative called Implementation Through Partnership, ITP, which for medical doctors is actually a blood disease, but that's a different story. And it's a preliminary approach that I think will grow and become part of the way we normally do business of analyzing the financial utilization, because it's an early marker for weak implementation, and finding and identifying countries that seem like they might be at risk of both initially underutilizing funds that are allocated and ultimately falling short on impact. And as we've convened in the last 6 weeks 20 country meetings with at least 10 to 20 to 30 partners each for each of those discussions, one of the areas that comes up more emphatically than most of the others is procurement and supply chain. And so there have been, each of those 20 country meetings has been followed up or is being followed up with a country visit with partners around the table, with CCMs, with PRs and government to say, okay, here's what we all think are some of the big bottlenecks, and here's a plan that we will work on together with mutual accountability and mutual visibility for how we approach that. And I think supply chain is at or near the top of that list. So it's definitely something that's on the radar screen. And so it gets back to the yes, no. It's our responsibility to be engaged in that and to support the things that need to be supported. But we can't do that without partnerships. And so this ITP is we're very excited about it, a more formal way to do this with partners.
Thank you.